Continuous curvilinear capsulorhexis. How to get it right? Nearly every time. Nearly perfect CCC looks something like this. There we start with a nice raised flap, move curvilinearly with shearing forces, and then end with a nearly perfect circle. It needs two very important things: central fixation, chamber maintenance with hardly any viscoleak. It doesn't always happen. There can be an uncooperative patient with excessive Bell's phenomenon. The rhexis may run off, or it can be the deadly Argentinian flag sign that is seen. As beginners, there will be lots of questions. First one would be to stain or to not stain. It's pretty obvious that to stain would be the way to go. How do we stain it? Use the side port. It should be under an air bubble. 0.2 to 0.5 ml injection of 0.03% trypan blue for 15 seconds, especially to be used when red reflex is dull or absent. Situations where staining can be avoided: decent surgical experience, good red reflex, and a good microscope. What instruments do we use? Most of the times, a humble cystitome works. In mature cataract, we'll need Utrata forceps or capsulorhexis forceps. Calcified capsule requires Vanas. Hypermature cataract or rhexis runoff requires micro instruments like microrhexis forceps and micro scissors. The humble fixation forceps is of extreme use, especially in situations where the patient is uncooperative. We fix it using the fixation forceps in the left side port, and with the right side port we continue the rhexis. What incision do we do the CCC from? Always start from the side port. You can complete it with the side port, or we can shift to the main port to finish it. Where to start the rhexis? Anywhere is okay, but 180 degrees from the main port would be good. How do we progress? With shearing forces. Initially pull towards the cystitome. Subincisionally, once it reaches the subincisional part, push away from the cystitome. When the rhexis flap is folded on itself, the faint line that is visible along the margins gives us a clue as to where the capsulorhexis is going. How do we end it? Always from outside the ring. So what are some special situations like mature intumescent cataract? In this, a small cruciate nick in the center is to be done. Aspirate the cortex with hydrocannula. Use viscoelastic to mobilize the leftover anterior cortex through the cruciate incision. Re-aspirate the cortex with hydrocannula. Spiral rhexis with forceps with intermittent viscoelastic injection is the way to go. We can use the rhexis with either Utrata forceps or microrhexis forceps. What to do in case of a rhexis runoff? Flatten the capsule and visualize the inner edge of the runoff. Perform Little's maneuver. Basically grab the inner edge of the tear and pull it towards the center. Notice how the rhexis tears inwards with this step. Then complete the rhexis with forceps. In young age or developmental cataract, the capsule is very elastic, so use ample visco. Flat should be lifted using cystitome, and then shift to either Utrata forceps or microrhexis forceps. Basically, little maneuver is performed all around the capsule. Keep pulling the capsule towards the center of the eye at each step, and then complete the capsulorhexis. What do we practice it on? Boiled vegetables. The cover on the IOL box. My personal favorite, the stretched plastic kite. Finally, it's a game of numbers. The more we do, the better we get. Small non-ophthalmic things that help, or at least that have helped me. Make a standard operation protocol list. Read before every OT. Share successes and apprehensions with colleagues. Keep the music on. Thank you so much for watching the video.